On behalf of the Patient Safety Authority, I'd like to welcome you to this webinar titled Avoiding the Clinical Equipment Landmines, WellSpan Health's Mission for Zero Patient Harm. My name is Bob Yanish, and I'll be your moderator for this program. Is anyone familiar with our journal, Patient Safety? There's nothing we love more than highlighting the outstanding work done by our facilities, so please consider submitting your manuscripts. Along those lines, nominations for our annual I Am Patient Safety Achievement Awards are now open. Please email your regional patient safety liaison for more information for either. Now I'd like to introduce our speakers for the webinar. Robin Walker is the manager of WellSpan's Clinical Equipment Safety Program under Corporate Patient Safety. For over 30 years of experience as a bedside respiratory therapist, with a concentration in ICU care, her passion for quality and patient safety led her to a new role with the Quality and Clinical Improvement Team. During her time with the team, WellSpan's success in improving the care of patients with sepsis led to a national recognition. In Robin's current role, she is involved in all aspects of organizational safety related to the use of clinical equipment. Shannon Smith is the supervisor of clinical equipment requirements at WellSpan Health. She began her career at WellSpan as an application analyst supporting the in-house electronic health record and moved to her current role in 2016. With 25 years of experience in IT, 14 of those in healthcare IT, managing the clinical equipment review process was a natural fit. Shannon and her team were keenly focused on supporting WellSpan's goal of zero patient harm while navigating the rapidly changing arena of healthcare IT. Donnie Walters is WellSpan's founding director of medical equipment reprocessing and quality assurance. He served as WellSpan York Hospital's manager of central sterile processing for 6 of his 12-year tenure with the organization. Donnie's training began as an open-heart surgical first assistant in the U.S. Navy and is a 10-year veteran. His educational background is in biological sciences, microbiology, and virology, and holds a master's in business administration. Robin, I'll now turn the program over to you.
Thanks, Bob. We really appreciate the opportunity to share some insight into WellSpan's approach to safety as it relates to clinical equipment and supplies used throughout our organization and our mission for zero patient harm. In 2016, WellSpan recognized a need for a consistent and reliable approach to ensure the safety of our patients when medical equipment is used in their care. In response, our leadership implemented a 6-initiative program called the Clinical Equipment Readiness Team, or CERT, to procure, evaluate, and manage medical equipment. 2 notable teams of the CERT are the Medical Equipment Reprocessing Quality Assurance, or MERCA, and the Clinical Equipment Safety Team. As members of these teams, we are pleased to share our experiences of this unprecedented undertaking with you, avoiding the clinical landmines, WellSpan Health's mission for zero patient harm. Following the presentation, you should be able to articulate the structure of an effective recall management program, recognize the importance of a structured equipment onboarding process, and understand MERCA's equipment risk stratification scoring process as it relates to medical equipment and patient safety. The agenda today will begin with a brief overview of WellSpan Health, followed by my presentation of the Clinical Equipment Recall Management and Patient Safety Program. From there, Shannon and Donnie will walk you through the amazing work that the Clinical Equipment Review Team and the Medical Equipment Reprocessing Quality Assurance teams are doing every day to keep our patients safe from harm. WellSpan Health currently employs over 20,000 team members. We have 8 inpatient hospitals, including a behavioral health facility, and over 220 patient care locations. Services to the community include, but are not limited to, regional home health organizations, urgent cares, occupational health, on-site college clinics, sleep testing centers, and a durable medical equipment supplier. Geographically, we span across South Central Pennsylvania and Northern Maryland. Now I am pleased to begin my portion of the presentation entitled Clinical Equipment Recall Management and Patient Safety: the who, what, when, and how. Today I will review how recalls are received, who is receiving them, the benefit of system-level oversight, what information is needed for an FDA audit of a manufacturer recall, and how to create a process for urgent communication and mitigation of a patient safety issue related to clinical equipment or supplies. I think that it is worth once again noting the size of our organization. When I began my career at WellSpan 35 years ago as a respiratory therapist, there was no WellSpan Health, only York Hospital. No surgery centers, no med group practices, no urgent cares. A very different picture than what we see today. Not unlike many health systems throughout the country, we have certainly expanded. And while this growth has been positive, it also brings with it challenges in the way we function and communicate as a system. I like to call this diagram Manufacturer Recall Management 1.0. If you're like me, before I started my current position in patient safety, recall management seemed like a fairly simple process. The manufacturer identifies a problem, sends out a notice, you check to see if you have affected product, and if so, remove it, return it, and complete a manufacturer response form. Pretty straightforward, right? Maybe for Manufacturer Recall 1.0, but we are no longer in that class. More like Manufacturer 20.0. Let's look at some of the intricacies of this process today. The first step is to understand how recalls are entering your system. WellSpan Health had and continues to have multiple ways that we are receiving this information. Notices can be received in a paper form through standard mail, electronically, from vendors during an inpatient or an in-person interaction with staff, and also third-party distributors. How to get this information into a central repository so that it can be processed and communicated to all areas that may be impacted for investigation. Not only are recalls entering the system in a variety of formats, recall notices are sent to locations throughout our inpatient and ambulatory facilities. Some are sent directly to supply chain, biomed, or pharmacy departments, some to risk management or patient safety. Others are received in ambulatory sites. Again, how to ensure that information received in one department or facility is shared everywhere that might be using this device or product. We quickly identified a need to get all correspondence funneled into one location. A mailbox was created and named Product Alerts at wellspan.org. Staff are instructed to forward any information received related to a recall or device correction to this mailbox. We also have been working with manufacturers directly to send communication to this mailbox. In 2016, WellSpan partnered with ECRI, or the Emergency Care Research Institute, and utilizes their Alerts workflow platform to assist in management of our recalls. Alerts workflow communicates manufacturer recalls to our team members and also gives staff the ability to place documentation within an alert. Documentation includes things like, did we have the product or device? If so, how many? What was done with the affected product or device? We also have the ability to upload any documents related to the recall, such as a completed response form or communications that we may have sent out to patients. If WellSpan receives a recall that is not found in ECRI, the information is submitted to them for posting. So far today, we've identified formats in which recalls can be received, locations that may be receiving them, and the importance of having a method to ensure information is funneled into one location to review for system awareness and spread. Next, I would like to talk about the type of information that is found in manufacturer recalls. I use the term recall, however, many of the notices are titled urgent medical device corrections or product notices. With more and more frequency, we are no longer getting instructed to pull it off the shelf, but instead, end users should do this before using the product, or a software update is coming, but until then, do this. Recall management is touching staff that historically would not need to be involved in this process. The bulk of the work remains in supply chain, biomed, and pharmacy, what we refer to as the big three buckets. While those areas remain key stakeholders in recall response, bedside clinicians are more and more frequently being pulled into the process. It's complicated. How to identify areas that might be impacted by an update to contraindications for use of a mask used for a CPAP device. Masks are found in the acute care setting, pulmonary offices, sleep centers, and DME locations. What about a recall on an endoscope when the procedure is sometimes conducted in the gastroenterology suite, sometimes in the OR, maybe in your ambulatory surgery centers or endoscopy centers, maybe in your ambulatory practices? An accurate, up-to-date asset list is essential. What about the urgent medical correction for a robotic system that needs communicated to all providers that operate the device? How to ensure the information is communicated to physicians before their next case? What about the OR staff? What if a piece of equipment is found to have a cybersecurity risk? I would like to say that we have it all figured out. We do not. But what I can say is that we are in a better place than we were a year ago. When I think about how our program started and the foundation put into place to make it successful, three things come to mind. A system policy was created for alert and recall management that outlines our structure, including roles, responsibilities, and expectations. The policy also includes key performance indicators around alert response and an escalation plan for noncompliance. We have chosen to monitor the number of alerts that have no response, the number of days to alert response, and completeness of documentation. Goals were established and a dashboard created that is shared at our monthly system patient safety meeting. Audits are conducted monthly, and any staff member that falls outside of our standard receives an email that contains a scorecard representing their performance. This communication is also shared with their manager and the facility patient safety officer. Developing relationships and communication with staff has been one of our biggest wins. This work is not easy and is sometimes looked upon as just another task in an extremely busy workday. I have found that everybody really wants to do the right thing for our patients. The staff needs to understand expectations, the why behind it, and feel supported when they encounter barriers to success. I talked a little bit about how response to recalls has required some restructuring over the years. The current environment, including supply chain challenges, has further complicated our ability to mitigate recalls due to equipment and supply shortages. As the type of recalls requiring system involvement outside of the normal workflows became more frequent, we recently adopted a process already in place for patient safety calls to quickly get stakeholders to the table, discuss the recall, the impact to the system, and put mitigation steps in place to ensure patient safety and staff safety as well. Stakeholders on the call may include leadership from supply chain, biomed, pharmacy, risk management, legal, patient safety, infection control, department or service line leadership, and also communications. Recently, we had a recall for a suction irrigator used in several of our ORs. The recall informed us of a risk of fire when using this product. We joke that these recalls are released intentionally on a Friday afternoon just to ruin our evening, But this particular recall was received on a Thursday evening prior to a 3-day holiday weekend. Supply chain was notified of the recall and very quickly escalated to our team that pulling the product would deplete our supply at some of our hospitals and potentially cause surgery cancellations. As a device safety notification call went out, within hours, we had identified which facilities were impacted, where we had an acceptable substitution, and if we had enough of the substitute to ensure that scheduled surgeries would not have to be canceled. The recalled product was pulled, substitute product was redistributed, and orders were placed for the replacement. The crisis was averted. I want to touch on record keeping and documentation. Why is it important to keep such detailed records of recall management? Well, I can tell you why. A call from your friendly FDA representative. I have received several calls over the years, and they always make my heart stop for just a moment. Will I be able to provide the information needed? Do I have the documentation to support it? Knowing what questions will be asked and what documentation needs to be produced will keep you way ahead of the game. This slide bullet points the questions that have been consistently asked during an audit. Keeping system-level information in a central repository that staff can access instead of each facility or department maintaining their own records is vital. I joined the corporate patient safety team 3 years ago. My role was to include management of the recall process, which my then director predicted would take perhaps 10% of my time. I thought, how can this be? Again, going back to Recall Management 1.0. The workflows had been put in place 3 years prior, and while fully functional when created, lack of consistent oversight and management had created gaping gaps in the structure. This became very apparent when discussions were started around integration of the recall process for 2 of our most recently acquired hospitals and their ambulatory practices. There were many variances in the 2 processes. No one person was solely dedicated to recall management in either of the processes. The work was found to be very fragmented. We needed to determine what was working and what wasn't. We needed a solution that would pull everything under one umbrella. With the help of our performance improvement team, an A3 was completed. The outcome was the creation of a new position on our patient safety team, the alerts and recall specialist. Whether you have your own home system or use a third party such as ECRI to help organize your recall process, having a person fully dedicated to the work is a huge asset. We were incredibly fortunate to find someone within our organization who had the perfect skill set needed for our position. Jose Anaya Santos had 5 years of experience in supply chain logistics and distribution. He has a vast knowledge of medical supplies and who uses them, but also understands how to drill down into purchase history reports to determine where a recalled product may be located. Having him on the team has definitely added an additional layer of safety for our patients and staff. He's an incredible resource to our team members throughout the system. This work, again, is not easy. There are a lot of questions. Having Jose available to provide support to staff is invaluable. I am very happy to share that with Jose's help, we have completed the standardization of recall management throughout our health system. Let's review some of the key takeaways for a successful recall management program. Organizational oversight of your process to ensure that policy is followed. Response to recalls standardized and monitored. Documentation and manufacturer response forms are completed and returned. Your policy should very clearly state roles and expectations and should include an escalation path for staff who fall outside of expectations. Set up a designated mailbox for staff to send manufacturer notices for system awareness. Create a communication workflow for issues involving clinical equipment or supplies that requires mitigation outside of your normal process. Keep a central repository for recall-related information and documentation. Create key performance indicators, audit, and communicate opportunities and wins. The saying that it takes a village definitely applies to recall management today. The relationships and resources needed to be successful in our mission for zero patient harm looks much different than it did even 2 years ago. We currently have over 1,000 staff directly engaged in ensuring prompt, efficient response to recalls throughout WellSpan Health. It really does take a village. I thank you for your attention, and with that, I'm going to hand it over to Shannon, who will provide an overview of our clinical equipment onboarding process, best known at WellSpan as CERT. Shannon, I will now turn the program over to you.
Thanks a lot, Robin. Really appreciate that. So hi, everyone. I'm Shannon Smith. I'm super excited to be here, and I look forward to presenting a process that we're extremely proud of and that we feel plays a really important role in our goal towards zero patient harm here at WellSpan Health. And the process is the clinical equipment review process, or what we call CERT. So Robin touched on recalls and alerts management, and we actually leverage some of the work that Robin's team does when we make decisions about bringing equipment into the system. So I'll explain how we factor this information into our decision when deciding whether to bring the equipment in or not. I'll explain how that information is used a bit later in my presentation. So I'll be covering a lot during my time with you. I'm going to be explaining what the CERT process is, who at WellSpan makes up the team, how the process is facilitated, and I'll also touch on our equipment scoring system. And this system allows us to decide whether or not to bring, whether or not we need to complete a clinical equipment review process or not. Certain equipment doesn't score high enough. So I'll go into that a little bit later. So at the end of my presentation, I hope that you'll be able to recognize the importance of a structured equipment onboarding process and understand how to document and track outcomes of a clinical equipment review process, and see how we build our formula for assessing patient and organizational risk of equipment that we bring into the system. So the clinical equipment review process is a cross-functional clinical onboarding process. It ensures that WellSpan Health understands and accepts both the patient and organizational risk of acquiring and using clinical equipment. We developed the process in 2015, we piloted it and fully implemented it in 2016. And so as you can see, we've been using the process for some time. It's changed a lot over the last 4 years. Process looks very different than it did in the beginning. We affectionately refer to our early days as baby CERT. Honestly, we just didn't know what we didn't know. And so we've learned a ton. So it's really grown since then. We've added many new stakeholders along the way. When other departments heard that the equipment ordering process depends on the successful completion of CERT, they were very interested in being involved. And this process touches any hospital or practice that is part of WellSpan Health. It is the first step that's used when acquiring clinical equipment. Supply chain services actually doesn't even cut POs until all parties involved in onboarding, maintaining, and using the equipment understand the expectations of doing so. So I want to dive a bit into patient risk here. So how do we minimize the risk to our patients when bringing clinical equipment into the system? We do this by ensuring we understand as much as possible about the equipment. Things like how the equipment is used. We spend considerable time reviewing documentation. We look at manuals. We spend time on YouTube looking at vendor videos, and we look for any other relevant information that might be helpful in us determining the full use of the equipment. We absolutely have to have a clear understanding of how the equipment's used at WellSpan Health. We determine if the equipment contacts our patients or only plays a supporting role in their care. And this information is used as part of our equipment scoring system, and I'll go into that a little bit more later. Avoiding patient risk also involves understanding how equipment should be cleaned or disinfected. This is the key factor in avoiding patient harm. We collect manufacturer user manuals and cleaning and disinfection instructions. Those are thoroughly reviewed and understood, and there are some different ways that we use this information. So let's just say that there's a piece of equipment that has a wipe down protocol. So we ensure that the user understands what chemicals are approved for use on the device. That might not seem like a very important thing, but if you understand that the wrong chemical can affect the long-term functionality of the equipment and increase the likelihood of patient harm, and can even void a manufacturer's warranty, then you start to see the importance of considering this information. We determine if something needs to be high-level disinfected or sterilized, and if it does, we involve our central sterile processing team. We really need to understand if they can accommodate the new disinfection cycle, or if as a team, they need an in-service training from the vendor. We also have equipment that sometimes requires more complicated cleaning protocols, and Donnie will dive into that a little bit more in his presentation later. But when that is the case, we work in tandem with Donnie's team, which is MERCA again, Medical Equipment Reprocessing and Quality Assurance, and the requester to create and approve standard work cleaning documents that are used during Donnie's team's audits. And again, Donnie will dive into that a bit later. Avoiding patient risk also involves understanding how equipment is maintained. Does it require regular preventive maintenance? And who is to perform that maintenance? Is it something that is done by the user? Is it something that has to be done by the vendor? Or can our biomed team do that maintenance? We need to understand whether or not we need to have spare equipment on site for when the other equipment needs maintenance. In addition, staff training is a huge piece, and it plays an essential role in avoiding patient harm. So my team works really closely with our clinical education staff. We ensure that user training is completed and documented in our learning management system. And our motto is, if it wasn't documented, it didn't happen. Documenting this education presented a ton of challenges in the beginning of CERT. But by working with our education staff, we were able to develop ways to better capture this information. And today we provide education templates, and this helps provide consistency in this area. Another factor that we consider when bringing in clinical equipment is the risk to the organization. So maybe organizational risk isn't the first thing that comes to mind when you think of clinical equipment. So what does avoiding organizational risk actually look like? So it involves several factors. So one important factor is how the equipment interacts with PHI. And PHI is defined as protected health information and includes things such as a patient's name, their medical record number, their date of birth, their address, or any other information that can be used to identify a patient. We consider if PHI is processed, stored, or transmitted, and if so, what protections the manufacturer allows on their device to protect this PHI. We work really closely with our IT security team. They help us determine the security requirements for that device. And once we get that information back from that team, we actually will reach out to the manufacturer and we'll validate that they can meet these requirements. And if not, we often escalate to our senior management team, who must then determine if the benefit to our patients outweighs the risk to the organization, or if we should look for alternate equipment. We also factor in network connectivity requirements. Does the use of this equipment negatively impact our network performance? Will the equipment allow for system patching to protect against attacks? Can the device be encrypted? And this is especially important in cases where PHI is stored. We must protect patients' PHI throughout the entire life cycle of the equipment. It's our responsibility and we take it very seriously. Another thing we consider is whether there's a vendor PC or tablet included with the purchase. Can we install our standard controls on that tablet or PC? Things like antivirus software, whole disk encryption, or remote support tools. Obviously, our organization prefers to have a WellSpan PC or tablet used with equipment, but sometimes that's not possible. So we really need to figure out how we can mitigate those risks when we have a vendor PC or tablet with the purchase. We also ask whether there's new software that must be supported in-house. We need to understand what's required to support that software. Do our IT applications teams have the capacity to take on additional software support? We must also thoroughly understand how the equipment integrates with our other IT systems, such as our patient monitoring system, our electronic health record, our picture archiving and communication system, and so on. So what work is needed to ensure a successful integration with these systems? And do these integration teams have the capacity to take on the work? We strive to ensure a smooth onboarding process. It's important to our patients and to our clinicians. And so to date, through the CERT process, we've reviewed over 1,500 unique pieces of clinical equipment, and we created centralized documentation for user training, cleaning, disinfection, and ongoing maintenance for that equipment. So who actually makes up the CERT team? We have both primary and secondary stakeholders. Our primary stakeholders I have listed on the left side of the screen here. They include Biomed Engineering, MERCA, which again is our medical equipment reprocessing and quality assurance team. And this team is part of corporate infection control. The Office of Production Quality, which is one of the IT teams here at WellSpan, is the team that I work on. And we actually facilitate the clinical equipment review process. Of course, we have organizational learning and development and clinical education, whose focus is staff education, and supply chain. Those are our primary stakeholders for CERT. We also have many secondary stakeholders. They're listed on the right side of the screen here. And these teams are invited to participate as needed, so they're not required on every single CERT call. So some examples of those teams include accreditation and licensure. So they're interested in determining if there needs to be a reporting done to the Department of Health for this clinical equipment, central sterile processing, when equipment is going to be cleaned by that team, facilities and design and construction for equipment introduced during expansion or renovation projects. Recently, hazardous materials reached out to us and they wanted to be included because they're interested if a piece of clinical equipment is going to introduce a hazardous chemical into the system. They want to be in front of that instead of behind it, which was the case in a lot of times. Imaging safety, is the equipment safe to be used in an MRI environment, or does it emit or measure radiation? And of course, patient safety. Value analysis, we work really closely with them on looking at the consumables that are needed for clinical equipment. They also pull reports for us, the MAUD Alerts and Recalls report. And MAUD stands for Manufacturer and User Facility Device Experience. So if we find significant concerns around equipment, we escalate this to Robin's team and get them heavily involved. Other secondary stakeholders are our various IT teams like networking, end user computing, IT security, project management, our server team, and so on. Obviously, not every piece of equipment has network or IT components, but when it does, we ask for input from the impacted teams. So now I'm going to walk you through how the process works. So it starts when equipment is budgeted. This obviously requires advanced planning, including consideration of the service line's goals. Then the requester will obtain quotes from the vendor or manufacturer, and then they'll request the equipment through our intake system. At this point, the request comes to my team and we score the equipment. And this will allow us to determine whether it requires a review or not. I'll be diving into that scoring system a little bit deeper in the next slide. So if the equipment does score high enough for CERT, the facilitation submission. So the first thing we do is we reach out to the vendor and the requester and we ask them to complete a comprehensive questionnaire. And this helps us gather all the details about the equipment. Each of our primary stakeholders was instrumental in the development of this questionnaire, and they actually own their corresponding sections and can ask for changes or updates when warranted. And previously mentioned, CERT is a cross-functional process that depends on each team for success. So we use this questionnaire to gather the specifics about how the equipment's used, the proper cleaning and disinfection, maintenance requirements, staff training needs, IT components, and so on. Then we collect all the supporting documentation from the equipment manufacturer, and that includes things like user manuals and service manuals, any cleaning instructions, any IT documents. And we store all of the documentation that we collect and discover during this review process on our clinical equipment review SharePoint portal. This portal is open to anyone, and they can go out there at any time to find out information about a particular piece of equipment. And it allows us to document details like where the equipment will be used, who requested it, when it was delivered to the location, and so on. Next, we research, or actually our value analysis team researches the mods, alerts, or recalls. Once we complete all of these steps, then we actually hold the review call. The entire team, which includes all primary stakeholders and any secondary stakeholders, assemble on a video conference call with a vendor and manufacturer rep and the requester. And this gives everyone on the team an opportunity to ask any questions about the equipment. And this will help us determine if it's a good fit for WellSpan Health or not. Following this call, my team sends out meeting minutes to all of the participants. Next, we complete any pre-purchase actions from the meeting. Then purchase approval is granted and the purchase order is issued. Next, we look at readiness requirements. Were there any identified during the clinical equipment review? And readiness items are identified by the call participants during the CERT call, and they're defined as any activity that must be completed before the equipment is put into clinical use. And some examples of equipment readiness would be things like staff training, which is our most frequent and common readiness, and central sterile processing or biomed in-service training. We also have instances where we need a standard work cleaning document. Say that there's a piece of equipment that's being brought into the system that has a complicated cleaning process. So the standard work cleaning document must be written and approved prior to the equipment's use on our patients. Then the equipment arrives and is checked in by Biomed. Biomed adds it to their inventory. They set up any maintenance schedules. They document the owning location. And then the equipment is delivered to the requester for patient use. And at this point, the CERT review is completed. So what happens if the same equipment is requested again? We actually communicate what we learned during the first review to the new requester. And that way we don't have to have a secondary call. We ensure that all readiness items are completed for that specific purchase. And we assist in creating the work order for the equipment check-in for that location. So maybe you might wonder if every piece of equipment is approved. And the answer is no. So since CERT's inception in 2016, we've denied the acquisition and use of 41 devices. Some examples include patient recliners and patient scales. And so both were denied due to potential tipping hazards that could lead to patient falls. We also denied some exam lights because they had high failure rates. We denied a cardiac fibrillator that had not received FDA clearance, and I think Donnie's going to discuss that call with you a bit later in his presentation. We also denied some fluid warmers because they didn't receive the approval due to urgent medical device recalls discovered during our CERT research. A cardiograph was denied because of outdated software and no plans were in place for future upgrades. So as you can see, the work this team does is critical in supporting our mission of zero patient harm. So now I'm going to explain the clinical equipment scoring methodology. Our equipment scoring system is based on several factors. The first factor we consider is the consequence to the patient if the equipment fails. And this is a rating that's determined by our biomed team with input from the vendor. The next thing we look at when scoring equipment is any equipment readiness requirements that are likely to apply to this equipment. And obviously, once we hold the call, these can change, but it gives us a starting point for scoring purposes. What we're trying to decide here is if we need to spend the time and the energy to put this equipment through CERT. Does it score high enough to warrant a review? So again, things like staff education, central sterile processing training, and biomed training are examples of equipment readiness. Then we're going to factor in the patient risk. So what is the risk to our patients? We actually use the equipment risk assessment portion of the MIRA scoring matrix, and Donnie will go into that a little bit later, but MIRA stands for Medical Equipment Risk Assessment. Then we factor in preventive maintenance requirements and other IT relevance. So does the equipment communicate to a cloud system? Is it network capable? Does it process, store, or transmit PHI? And so on. So on the left side of the screen here, I've actually laid out the formula for you. So we actually take the consequence to the patient if the equipment fails. We add in any readiness requirements. We multiply that by the risk to our patient, and then we add in any considerations. So if the equipment scores less than or equal to 7, then it's very, very low risk to our patients and doesn't warrant a CERT review. If it scores higher than a 7, then we will put it through our CERT process. So on the right side of the screen here, I have a couple examples of scoring. The first one is an anesthesia machine. So the consequence to the patient if the equipment fails is potential death. So that receives a 5, which is the highest score. We have 3 readiness items for this equipment. It requires staff training, central sterile processing for the cleaning of some of the components, and corporate infection control is requiring a standard work cleaning document. So all of those things were factored in. Then we look at patient risk. Again, it scores our highest score of 5 because it's invasive to our patients. Then we look at any other considerations. It's network capable and preventive maintenance is required. So down below, you can see what our formula is. So we start with consequence. We add in any readiness. We multiply the patient risk, and then we add other considerations. And this equipment scores 145. So obviously this one falls squarely within CERT. And on the other side, we have a warming cabinet, and this is actually a warming cabinet for patient towels. So the consequence to the patient if this fails is no consequence. Therefore, it gets a 1, our lowest score. The readiness for this is staff training. Obviously, we still want the staff to understand how to use the equipment, so we'll require them to be trained. The patient risk, it's not used in direct patient treatment, so it gets our lowest score. And then any other considerations for this equipment, it does require preventive maintenance. So again, applying our formula, we get a 7. So this equipment would actually not require a CERT review. So this is actually completes my portion of the presentation. So I'd like to revisit some of the goals that I set forth for this presentation. I covered what the CERT process is, what makes up the team, how the process is, who makes up the team, how the process is facilitated, and I explained the equipment scoring system we use to determine if something qualifies for a CERT review or not. I hope you were able to recognize the importance of this structured clinical equipment onboarding process and understand how we document and track outcomes of our clinical equipment review process, and also how we build a formula for assessing both patient and organizational risk. Now I'll turn it over to Donnie, and he's going to provide an overview of how we audit the medical equipment that's vetted through our CERT process. Back over to you, Donnie.
Thank you, Shannon. Welcome, everyone. It's my pleasure to be with you today. Again, I'm Donnie Walters, the founding director for the WellSpan Corporate Infection Control's Medical Equipment Reprocessing Quality Assurance, or MERCA department. WellSpan Health has made a commitment to ensure patient safety by performing periodic medical equipment audits through the organization. MERCA audits the maintenance, cleaning, disinfection, sterilization, processes, and competencies for all of our frontline staff across facilities in York, Franklin, and Adams counties of South Central Pennsylvania and Northern Maryland. And while we have expectations for all equipment hygiene across the system, MERCA's focus is centered on high-risk equipment as this poses the greatest risk to our patient population. Our team of auditors is deployed to any of our facilities where there are questions raised regarding the cleaning and disinfection of medical equipment, medical devices, or surgical instrumentation, whether currently in use, in short or long-term storage, or whether the equipment has had preventative maintenance performed at specific time intervals. MERCA is also called upon during D&V, Joint Commission, or Department of Health surveys regarding medical equipment reprocessing, thus acting as a liaison between the surveyors and our facilities to address any equipment reprocessing concerns. We do this for transparency, clarity, and if necessary, process remediations. The auditors at MERCA assess, manage, and monitor equipment to patient risk by three basic categorical means. The first is how equipment touches the patient, or its physical contact risk. This involves the qualitative classification of equipment to patient risk by means of therapeutic usage, whether it's a blanket warming machine or a total joint implant. MERCA studies and applies this assessment, along with others, to what we developed as our very own Medical Equipment Risk Assessment, or MIRA score, combined with the Spaulding classification of medical devices, which I'll discuss a bit more in detail later. Secondly, we look at the equipment's location risk. The assessment involves a process for analyzing the critical areas to where medical equipment is used and categorize these locations by a level of patient acuity. In review of these locations, MERCA depends on the WellSpan's biomedical equipment department to assess where the equipment lives and how it moves throughout the facilities in audit. This assessment can be done either by an electronic equipment database, a surgical instrument tracking program, or by equipment tracking devices such as radio frequency identification or RFID tags. And third is the equipment hygiene maintenance risk. This assessment calls for the use of both qualitative and quantitative indicators to help indicate whether or not the MERCA team assesses the patient risk related to the disinfection and preventive maintenance of medical equipment in the areas they live. Just as with the physical contact risk, we depend on the recommendations for the care and preventive maintenance of our medical equipment as prescribed by the manufacturer's instructions for use, or IFU. The Pennsylvania Department of Health and the Food and Drug Administration are also factors for which we look at for that equipment's physical risk. The WellSpan cert process and our frontline staff members are also directly responsible for the hygiene of medical equipment between patient use. Establishing baseline for medical equipment primarily depends on the MIRA score, for which I mentioned, and the end user's cleaning competencies. Our audit frequencies are usually scheduled around 3, 6, and 12-month intervals. Prior to scheduling an on-site process observation, MERCA auditors will review the current manufacturer's instructions for use for all equipment to be audited. Then we'll begin to prepare the process observation document, which will guide the audit from beginning to end. And at its conclusion, the audit will review all areas included in the equipment audit, and it will include the manager and the frontline staff who performed the cleaning and disinfection of that equipment as part of the audit process. Documentation of the on-site observation require auditors to have excellent writing skills to accurately document the current state cleaning process, including any deviations from the equipment manufacturer's instructions for use. And then we make recommendations for reprocessing compliance. And if the equipment reprocessing is observed to be severely outside of the manufacturer's instructions for use, auditors will elevate the observation in real time to me, the MERCA director, for further guidance or elevation to senior leadership. Assessment of equipment risk is determined by a risk stratification scoring matrix, or the MIRA score, as I mentioned earlier. This scoring process includes, but is not limited to, the grid here you see on the screen, which is labeled risk assessment on the vertical axis, and the corresponding equipment physical risk just below the grid on the left column. Please note how these touch points are categorized. For example, if the equipment is invasive, holds water, has been recalled for safety events, or has been implicated in patient deaths or serious injury, has our highest score of a 12. The point of care location risk, which is labeled atop the horizontal axis of the grid, has a corresponding point of use location labeled below the grid in the right column. Examples include, but are not limited to, ORs, ICUs, APUs, and cardiac cath labs. These locations are scored at a 5, indicating the location of highest patient acuity for the column. The risk multiples from both the vertical and horizontal axes of the MIRA chart are combined to provide the MIRA score. If you recall earlier, I mentioned that we combined this score with the use of the Spalding classification for medical device reprocessing. This MIRA scoring matrix allows MERCA to categorize equipment risk from low, in multiples between 1 and 9, shaded in green, to high, in multiples between 12 and 60, shaded in red. So let me give you an example of how the MIRA scoring system works. I want you to visualize a piece of equipment called the GE Healthcare Giraffe OmniBed Care Station, which is a bed used in NICU, or neonatal ICU. First, MERCA assesses the equipment to patient risk by choosing the multiple which best aligns with the equipment's components and its physical contact with the patient. Based on our equipment review, we know that the equipment holds water in a humidifier reservoir per the manufacturer's instruction manual. So we begin at the left column of the chart reviewing the categories. We assign the equipment risk number a 12. We also know that the equipment is used in NICU, so we assign the location risk number as a 5. Now we take the two multiples, 12 times 5, and a score is bored out at 60, which is our highest MIRA score, indicated in the red area of the grid. Any equipment lower than 12, which is 1 to 9, as I mentioned earlier, are considered to be lower risk. Using this score as our guide, MERCA can now make recommendations for the level of equipment reprocessing requirements and determine the frequency for which the equipment is audited. Again, using the Spalding classification as a guide to determine the equipment criticality, this helps us recommend the equipment reprocessing requirements to the end user. Some components of the equipment may need only a low to intermediate level disinfection, while others may require high level disinfection or even sterilization. I'd like to give you another example to illustrate how the MIRA score works. I want you to think about the intuitive robotic system used during surgical procedures. While the robot itself does not require sterilization, the unique arm attachments do. In reviewing the robot only, MERCA will assign the equipment risk score a 1 and the point of care location at a 5. So the MIRA score in this case is only a 5. It is important to note here that the assessment is specific to the robot itself, which is separate from the sterilized attachments, which in and of themselves would be a MIRA score of 60. It would not be appropriate to assign the robot itself a risk score of 60 because the robot is not invasive, but rather the arms to which the robot is used are, thus requiring a separate review, which will take place in our surgical instrument and low MIRA call, a secondary CERT review that does not require the breadth of participation as that of the CERT. So how are the two different? The giraffe bed came in as a 60, and it's not invasive, yet the robot, which is used in surgical procedures, comes in as a 5. The difference is the giraffe bed comes into contact with the infant directly. It also has humidified air bored from a reservoir that holds water. The infant breathes that air inside the bed. If that reservoir is not cleaned properly, It can collect mold and bacteria, which can create extraordinary risk to NICU babies. Again, the robot, a mere score of 5 due to its indirect contact with the patient, and the giraffe bed that poses greater risk to, and its attachments come into direct contact with the patient. My hope here is that you're conversant in the way that the mere score works to provide MERCA with a consistently reliable way to assess equipment risk throughout WellSpan. It is the means by which we recommend the purchase of medical equipment. Now, there have been instances where we have not recommended the purchase of medical equipment or a device for use on patients within our health system. I recall a time where there was once a medical device submitted to the CERT for purchase approval, and it was a cardiac fibrillator that Shannon mentioned earlier. As with many devices, MERCA saw this as a routine review for surgical equipment until we began to dive deeper into that research in preparation for the clinical equipment call. During our research, we had discovered that the sale of this equipment had been criminally sanctioned by the FDA, as the manufacturer who designed and engineered the device modified it and had not submitted those modifications to the FDA for approval. The FDA warned in several letters that if the manufacturer continued to sell this product within the US, he could be brought up on criminal charges. I use the pronoun he because the manufacturer was the lone gentleman who apparently created this product, independent of well-known manufacturers such as GE Amersham, Gentex, Sarnes, or Pilling-Weck. Prior to the upcoming call, MERCA auditors knew that this was going to be a contentious review. So when they approached me with their research, I asked them if I could take lead on the call, as the research could pose a contentious situation, as MERCA would not be recommending the purchase of this device. During the CERT review, as expected, we found ourselves in an uncomfortable position, which on one hand, we were advocating for our physician requester, while on the other hand, we required the manufacturer to produce documentation for when he settled his dispute with the FDA. This request caused the gentleman to engage in a heated exchange with our team. He tore into verbal strings of insults against the FDA, saying something to the effect of the administration was nothing but a bunch of money-hungry con artists, and that all the FDA wants to do is suck money from manufacturers, and that he refuses to entertain our concerns regarding the FDA sanctions. Well, as the conversation escalated, the physician began to voice his frustration, along with the surgical director, who was attempting to minimize further disagreement between the manufacturer and MERCA. Conjecture appeared to come from all sides, all directions, and finally I interrupted the exchange with a stop, time out. I feel this conversation is no longer safe, and we're recommending that WellSpan does not move forward with the purchase of this equipment, and we will need to end the call. Our CERT facilitator, who reports to Shannon, immediately followed up stating that the call will be ending and CERT will not be recommend moving forward with the purchase of the device. Now I can tell you, because all calls are recorded, the minutes that were forwarded to senior leadership for quality review surely made me second guess whether or not I had done everything appropriately. I ran through every response I provided, and as everyone knows, we can be our own worst critics. But in retrospect, I maintained my composure and professionally represented our organization's highest values, our commitment to zero patient harm, and in search of minimizing patient risk. I felt we came out successful in this review. Once the leadership review concluded, senior leadership found that we, the CERT team, performed amicably and professionally, as this is what the process was designed to do, and it worked. It worked. So following the review, I debriefed the final resolution with the MERCA auditors, celebrating the fact that we were able to stop the line when patient safety was a concern, thus placing WellSpan in possible legal jeopardy. Now I want to switch gears for a minute. And as you've heard me mention a few details about the MERCA auditor's responsibility throughout my discussion, auditors are appropriately trained personnel who have no direct responsibility for medical device reprocessing, but possess prior expertise as subject matter experts in the field of equipment hygiene as part of their previous training and certifications. They must possess critical thinking skills for sterility assurance and have medical equipment reprocessing backgrounds to ensure that end users are competent in meeting the disinfection expectations of the manufacturer's instructions for use. MERCA auditors perform on-site observations with responsible frontline staff who clean and disinfect medical equipment in real time. Reprocessing deficiencies, if any, are identified and communicated to site managers in consultation with the MERCA director for remediation and ultimately compliance in accordance with all regulatory and surveying bodies to which WellSpan Health is accountable. In conclusion, we have found the medical equipment reprocessing quality assurance team to be a value-added department who works in conjunction with the CERT and patient safety teams to minimize equipment risk to both our patients and the WellSpan family of over 20,000 plus employees. This concludes the broad overview of medical equipment reprocessing quality assurance department's audit process, and it is my hope that by presenting this information, I've provided you with an understanding of WellSpan's process for assessing, managing, and monitoring equipment risk by using both qualitative and quantitative measures, such as the Spaulding classification for categorizing reusable medical equipment, in addition to our very own mirror scoring matrix, which helps us to determine the criticality based on both the equipment to patient and points of location risks. Finally, I hope that I've provided you with an appreciation for WellSpan's commitment to equipment hygiene by appointing me as the founding director and our auditors' roles and responsibilities within WellSpan's infection controls MERCA department. And with this, I'll turn it back to you, Robin.
Thanks, Donnie. Shannon, Donnie, and I have endeavored to provide you with a behind-the-scenes look at programs in place at WellSpan Health targeted at keeping our patients and staff safe from harm when medical equipment is used in our facilities. Our work is fully supported by leadership at the highest level of our organization. Zero patient harm is not just a nice slogan at WellSpan, it is our mission. Bob, I will now turn the program back over to you.
This concludes the slide presentation of our program. We'd like to begin our question and answer period. If you have questions, please type them in the Q&A box found at the bottom of your screen. Please click on the three dots, then click Q&A to open the Q&A panel and direct your questions to all panelists. We'll try to answer as many as we can. I know that we're a little over time, but I see we have one question that had come in. What is your biggest challenge when trying to standardize recall management?
I'll take that one. There were quite a few challenges, but once we had the structure in place, honestly, it's finding the right people. When you have as many people involved in the process as we have at WellSpan, you want to make sure that the people you're involving in the recall process have a very good knowledge of the equipment or devices that are used in their area, so they're not spending a lot of time just trying to figure out what it is that you're talking about when you're sending them some information about a product or supply that's been recalled. So getting the right people involved, I'd say, was probably our biggest challenge.
Great. Let's see. Another question. What is the first step in developing a clinical equipment review process?
Thanks, Bob. I'll take that one. So when we first started looking at this process, we looked at a process that we already had in place in IT. And the first step then was trying to identify the stakeholders that we needed to get at the table, to start asking the questions that we cared about as an organization when we brought clinical equipment into the system. And then once we identified those stakeholders, then we had meetings to determine what questions they wanted to ask of the vendors and the requesters so that they had a really clear understanding of what the equipment does and how it's used in the system. So the first step would be getting the right people together and at the table to start those conversations.
Okay, great. We're going to be ending the webinar soon, but we still have time for a few more questions. If you have a question, just type it into the Q&A box and we'll try to get to it. Let's see, another one. What challenges did you face when you initiated your audit program throughout the facility?
Oh, I'll take that one. Again, this is Donnie from Merca. Determining how much equipment or the volume of equipment throughout the organization was one of the greatest challenges. And to be able to right size that with the amount of auditors that we need. We're a very huge healthcare facility, over 22,000 employees, and we are spanned out over the York, Adams counties in northern Maryland. So that was one of them. So where it lives, was it currently in use? Was it in long or short-term storage? Was it being cleaned properly from patient to patient? Has it been maintained properly through biomedical or preventive maintenance? And one of the others was getting people used to the process. We often felt like people thought we kind of were like the feds when we came, like an IRS audit or something. And their initial response was to show us their best attributes to how they maintain equipment, which is fine. But I think what we needed to see is where their biggest challenges were. So we reassured them, showing them that, we are on the same team, and we needed to see the greatest risk. And that is, quite frankly, the person that would be most challenged in cleaning that equipment. That would establish the baseline for us to be able to help them. And so once we, and it's a work in progress, continue to have them get used to our presence and that we are on their side to make sure that that equipment disinfection is reliable and consistent and replicable. Then that was one of the biggest learning curves, but that's still a work in progress. But those were the biggest challenges.
Okay, we have time for one more question that came through. Have you been approached by other entities on an international level to learn your process and use it as a template for their standards?
I can
Not
take
yet.
Not yet. So not yet, but we welcome collaboration with anybody that's interested. At least I can speak for myself when I say that. We're pretty proud of what we've developed here, and we would love to share it.
I think
Absolutely.
you guys should definitely be proud. Again, I thank you, Robin, Shannon, and Donnie. This is just some great information, and I appreciate you being with us today. I want to thank everyone today for joining us. If you've experienced any issues accessing the evaluation or your certificate of education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. And this concludes our webinar.